Hello friends, today we are going to discuss about the Clostridium difficile infection in eyes. So Clostridium difficile is the anaerobic gram-positive spore-forming, toxin-producing bacillus that is transmitted among the human being through the fecal-oral route. So initially the Clostridium difficile was considered as an commensal organism, but now it is emerged as major enteric pathogen with worldwide distribution. Regarding pathogenesis and epidemiology, infection is transmitted by spores, which are resistant to heat, acid, and antibiotics. The spores are plentiful in healthcare facilities and are found in very low level in environment food supply, allowing for both nosocomial and community transmission. The colonization is prevented by barrier properties of fecal microbiota, uh, because the weakening of this barrier is responsible for the infection. So whenever we are administering that causative antibiotic, it is causing the weakening of this barrier, which allows the colonization and that leading to the infection. So not only antibiotic, but other factors are also responsible for this infection, like advanced age, antineoplastic chemotherapy, and severe underlying disease. So, what exactly happen when the person is getting infected with Clostridium difficile? So, basically the infection of this Clostridium difficile is mediated by toxin toxin A and toxin B, which inactivates the member of row family of guanosine triphosphatase, which leads to the colonocyte death, loss of intestinal barrier function, and neutrophilic colitis. So this infection is limited to the GI tract because the organism is non-invasive. And because of that, the infection outside the colon is extremely rare. The two factors that exert major influence on the clinical expression of the disease are virulence of the infecting strain and host immune response. This is the schematic representation of pathogenesis of the bacteria. So first risk factor is antibiotic, as I already mentioned, and other risk factors are advanced age, gastrointestinal surgery, inflammatory bowel disease, and immunosuppression. So what happened because of this? There is an abnormal colonic microbiota, which so because of that, the toxic Clostridium, there is an exposure of toxigenic Clostridium difficile and colonization, which also causes the activation of the prior colonization. So when this Clostridium difficile is producing the toxins, which is toxin tox-P, so if there is a no appropriate antitoxin response for this toxin, then that leads to asymptomatic carriage. And if it is there is an inadequate immune response, then that will then that then the patient will suffer from diarrhea or colitis. So in this stage, if there is appropriate response, then there is a resolution of symptom. And if there is an inadequate immune response or reinfection, then there will be the recurrence. So we'll see what are the risk factors. So most important risk factor for C. diff infection is antibiotic use. Amoxicillin, cephalosporin, clindamycin, and fluoroquinolones. These are the antibiotics that are most frequently associated with the disease. But almost all antibiotics have been associated with the infection. Paradoxically, major predisposing antibiotics show at least some in vitro activity against C. diff, and regimen include metronidazole, can both incite the disease and provide effective treatment. So there are antibiotics like metronidazole, which is responsible for the C. diff infection, and at the same time, we can use them for treating the infection. So we'll see what are the common antibiotics. So most common is clindamycin, then ampicillin, amoxicillin, cephalosporin, and fluoroquinolones. And somewhat common is other penicillin, sulfonamide, trimethoprim, sulfomethoxazole, and macrolides. And uncommon are aminoglycoside, bacitracin, metronidazole, teicoplanin, rifampicin, chloramphenicol, tetracycline, carbapenem, daptomycin, and tigecycline. In hospital and long-term care facilities, environmental contamination and frequent antibiotic usage are the risk factor for the infection. The risk of Clostridium difficile infection and the severity of infection increases as the age rises. So the infection of the Clostridium difficile is more when the person is older than 65 years of age. So the majority of the Clostridium difficile is hospital acquired, but the community acquired infection has dramatically increased in past decade and now may account for up to third of new cases. Community acquired Clostridium difficile is defined as the disease onset in person who had no overnight stay in healthcare facility within 12 weeks before infection. As compared to nosocomial infection, community-acquired Clostridium difficile infection occurs in patients who are younger, more often have had no clear exposure to antibiotics or other known risk factors. Major mode of acquisition of community-acquired infection is remained to be elucidated. Furthermore, the morbidity and mortality associated with community-acquired Clostridium difficile infection are lower than those associated with nosocomial infection. Because of the younger age and the fewer coexisting condition of non-hospitalized population. Up to 40% of patients with community-acquired infection require hospitalization, and rates of recurrence are similar among two populations. So the influence of acid suppression in Clostridium difficile infection remains uncertain. So there are few papers which showed the PPIs, the use of PPIs associated with Clostridium difficile infection. So in the now why there is evidence like that, because the theory behind it, the gastric PPI is causing gastric acid suppression, which allows the more vegetative organism to reach the colon. However, Clostridium difficile spores and the vector and infection, they are acid resistant and remain viable at gastric pH. So we don't know exactly. So whether these PPIs are responsible for the for a Clostridium difficile infection is or not. So now the risk factors are increased infection in association with acid suppression, advanced age, inflammatory bowel disease, organ transplantation, chemotherapy, chronic kidney disease, immunodeficiency, and exposure to infant carrier and infected adult. So the Clostridium difficile infection is associated with severe illness, infection-related mortality of 5%, and all-cause mortality of 15 to 20%. So severe Clostridium difficile infection is identified by white cell count more than 15,000, hypoalbuminemia, acute kidney injury, and these are also the independent predictor of urgent colectomy and death. Now, the risk factors for recurrent Clostridium difficile infections are include advanced age, severe initial episode of Clostridium difficile infection, ongoing use of antibiotic not directed at Clostridium difficile. Now, how to diagnose? So, if the patient with the unexplained and new onset more than 3 unformed stool in 24 hours, these are the preferred target population for testing Clostridium difficile infection. So we need to use the stool toxin test as a part of multi-step algorithm, like glutamate dehydrogenase plus toxin, GDH plus toxin, arbitrated by nucleic acid amplification test, or nucleic acid amplification test plus toxin rather than nucleic acid amplification test alone for all specimens received in clinical lab. Use nucleic acid amplification test alone or as a multi-step algorithm testing rather than toxin test alone when there are pre-agreed institutional criteria for patient stool submission. So what are the recommendations for diagnosis? If the patient is not on laxative and if the patient passed more than 3 stools in 24 hours for testing Clostridium difficile, then So if this is the clinical scenario, then the nucleic acid amplification test alone or stool toxin test as a part of multi-step algorithm can be used for the diagnosis. Otherwise, stool toxin test as a part of multi-step algorithm or nucleic acid amplification test can be used. So do not perform repeat testing during the same episode of diarrhea and do not test stool from the asymptomatic patient except for epidemiological studies. Now, how to treat? So first we have to discontinue antibiotic agent which is responsible for the C. diff infection. Now the antibiotic treatment should be started empirically for situation where substantial delay in lab confirmation is expected and in case of fulminant Clostridium difficile infection. So which antibiotic we should start? We can start either vancomycin or fidaxomicin is recommended over metronidazole for initial episode of Clostridium difficile infection. And the dosage of vancomycin is 125 mg orally for 4 times per day, or fidaxomicin is 200 mg twice daily for 10 days. So in setting where access to vancomycin or fidaxomicin is limited, we can use metronidazole for initial episode of non-severe Clostridium difficile infection. The only suggested dosage is metronidazole is 500 mg orally 3 times per day for 10 days. Avoid repeated and the prolonged courses due to risk of cumulative and potentially irreversible neurotoxicity. Now, what is the fulminant Clostridium difficile infection? Fulminant Clostridium difficile infection is the severe complicated Clostridium difficile infection, which is characterized by hypotension, shock, ileus, and megacolon. So, vancomycin should be administered orally as a regimen of the choice. If ileus is present, then we can administer vancomycin per rectally. So in this case, where the infection is fulminant, vancomycin should be used in the dose of 500 mg 4 times per day. Or we can use, in case of ileus, we can administer it per rectally. That is 500 mg in approximately 100 ml of normal saline per rectum every 6 hours as a retention. So, in case of fulminant infection, we can also use the IV metronidazole. Uh, should be administered together with oral or rectal vancomycin, particularly if IDS is present. The dose of metronidazole is 500 mg IV every 8 hours. So, in case of fulminant infection, we can also consider the surgical management. So which surgical management is so surgery that is preferred in this setting is subtotal colectomy with preservation of rectum, or we can go for diverting loop ileostomy with colonic lavage, followed by antegrade vancomycin flushes is an alternative approach that may lead to improved outcome. There is a strong recommendation for subtotal colectomy with preservation of rectum, and there is a weak recommendation for diverting loop ileotomy with colonic lavage. Now let's talk about recurrent Clostridium difficile infection. Treat first recurrence of Clostridium difficile infection with oral vancomycin as tapered or pulse regimen rather than second standard 10-day course of vancomycin. And there is a weak recommendation for this. And treat first recurrence of the Clostridium difficile with 10-day course of fidaxomicin rather than standard 10-day course of vancomycin. So if we use the vancomycin initially, then uh, or we can then we can use the metronidazole, or we can use and if we have to use the metronidazole as a primary episode, then we can take the standard 10-day course of vancomycin. So how to now if the patient has more than one recurrence of Clostridium difficile infection, then we have to treat this patient with oral vancomycin therapy using tapered or pulse regimen. Then we can also go for the standard course of oral vancomycin followed by rifaximin, or we can use fidaxomicin. We can also go for the fecal microbiota transplantation for patients with the multiple recurrence of Clostridium difficile infection who have failed appropriate antibiotic treatment. So we can actually transfer this fecal microbiota in case of in cases of the patient who are immunocompromised and who are developing recurrent Clostridium difficile infection. So we can put the inject tube and we can actually insert the slurry of this fecal microbiota so that it will help in it will help in preservation of that barrier and which will prevent the colonization of the Clostridium difficile infection. So this table provides the beautiful summary of the treatment of the Clostridium difficile infection in the adult. So it has divided the Clostridium difficile infection in non-severe, severe, fulminant, and recurrence. So let's see how to treat non-severe Clostridium difficile infection. According to this, the non-severe Clostridium difficile infection is where WBC count is less than 15,000 or there is no evidence of AKI. So in that case, we can treat it with vancomycin 125 mg 4 times daily for 10 days or fidaxomicin 200 mg twice daily for 10 days. And if none of these agents are available, then we can use the metronidazole, that is 500 mg 3 times daily per day for 10 days. So if initial episode is severe, but patient is maintaining hemodynamics, that means severe means if the WBC counts are more than 15,000 or creat is more than 1.5, then we can treat this patient with the vancomycin, that is 125 mg 4 times a daily for 10 days or fidaxomicin 200 mg twice daily for 10 days. And if the initial episode is fulminant, that means if it is associated with hypotension, shock, ileus, megacolon, then we can administer vancomycin 500 mg 4 times per day by mouth or by nasogastric. If ileus is present, then we can administer the rectal, we can administer this vancomycin per rectal. And only in this case, we can go for the IV metronidazole, that is 500 mg every 8 hours along with this. So there is a no role of IV metronidazole, but we can only use this in case of the fulminant infection. So if there is a first recurrence, then we can use the vancomycin. Then how to treat that? So we can treat it with the vancomycin 125 mg 4 times daily for 10 days. If metronidazole was used in the initial episode, or we can use prolonged tapered pulse vancomycin regimen if standard regimen was used initially. So what is pulse regimen? Pulse regimen is 125 mg 4 times per day for 10 to 14 days, then 2 times per day for a week, then once a day for a week, and then every 2 to 3 days for 2 to 8 weeks. So, or we can go for fidaxomicin, that is twice daily for 10 days if vancomycin was used for initial use. Then if there is a recurrence for more than one time, then we can again treat it with the vancomycin tapered or pulse regimen. So what is pulse regimen? Just now we have seen is that is 125 mg 4 times a day for 10 to 14 days, then 2 times per day for a week, then 1 time per day for a week, and then every 2 to 3 days for 2 to 8 weeks. Or we can also go for vancomycin 125 mg per day by mouth for 10 days, followed by rifaximin 400 mg 3 times daily for 20 days. Or we can go for fidaxomicin, that is 200 mg given twice daily for 10 days, or fecal microbiota transplantation. So I think along the all the regimen, the convenient regimen for the recurrence is vancomycin the combination of vancomycin and rifaximin, because the total duration of this therapy is 20 days. Or we can go for the fidaxomicin, that is 200 mg twice daily for 10 days. Pulse regimen of the vancomycin will take is a bit longer duration therapy. That is, it will last for 2 to 8 weeks. Now, the most important part is prevention. So, how to prevent this? So, if we know the patient is diagnosed with Clostridium difficile infection, we need to isolate this patient in the private room with a dedicated toilet, which decrease the transmission to the other patient. And if there is limited number of the private single room, then prioritize patient with stool incontinence for placement in the private rooms. So if we have to this patient, if cohorting is required, that means if we have to accommodate this patient together, then cohort the patient infected or colonized with the same organs. That is, do not cohort patient with difficile infection who are discordant for other multi-drug resistant organism like MRSA and VL. So, healthcare person like doctors, nurses, all the time they should use gloves and gowns on entry to the room of the patient with Clostridium difficile infection. And if the patient with the suspected CDI should be placed on the preemptive contact precaution pending C. diff result if test cannot be obtained on the same day. Continue contact precaution at least for 48 hours after diarrhea has resolved, and prolong contact precaution until discharge. If Clostridium difficile rate remain high despite implementation of standard infection control measure against the Clostridium difficile. In routine and endemic setting, perform hand hygiene before and after contact of the patient with Clostridium difficile infection, and after removing gloves with either soap and water, or we can go for the alcohol-based hand hygiene product. In a Clostridium difficile outbreak or hyperendemic setting, perform hand hygiene with the soap and water, preferably instead of alcohol-based hand hygiene product, before and after caring for patient with Clostridium difficile infection, given the increased efficacy of spore removal with soap and water. So please keep this in mind when we are dealing with the Clostridium difficile infection. Use this soap and water instead of alcohol base, because these spores are already alcohol resistant. Now, the hand washing with the soap and water is preferred if there is a direct contact with the feces or area where fecal contamination is high, like a perineal region. Then encourage patient to wash hands and shower to reduce the burden of spores on the skin. Then use disposable patient equipment whenever possible, and ensure that reusable equipment is thoroughly clean, disinfected, preferentially with the sporicidal disinfector that is equipment compatible. Then terminal room cleaning with the sporicidal agent should be considered in conjugation with other measures to prevent Clostridium difficile infection during endemic high rate or outbreak, or if there is evidence of repeated cases of Clostridium difficile infection in same case. Then incorporate measures of cleaning effectiveness to ensure quality of environment cleaning. There are limited data at this time to recommended use of automated terminal disinfection using sporicidal method of Clostridium difficile infection. Daily cleaning with the sporicidal agent should be considered in conjugation with other measures to prevent Clostridium difficile infection during outbreak or hyperendemic setting, or if there is evidence of repeated cases of Clostridium difficile infection in the same room. There is insufficient data to recommend screening for asymptomatic carriage or placing asymptomatic carriage on contact precaution. Minimize the frequency and duration of high-risk antibiotic therapy and number of antibiotic agents prescribed to reduce the Clostridium difficile infection risk. Implement the antibiotic stewardship program. Antibiotic to be targeted should be used based on local epidemiology and Clostridium difficile strain. Restrict the fluoroquinolone, clindamycin, and cephalosporin should be considered. Although there is an epidemiological association between PPI use and CDI, unnecessarily PPI should always be discontinued, and there is insufficient evidence for discontinuation of PPI as a measure of preventing Clostridium difficile infection. So in ICU setting, it's not possible to discontinue PPI every time, and there are inadequate studies which shown that discontinuation of PPI which help in preventing this C. diff infection. So it's so the final recommendation is not in more in favor of discontinuing PPI. There are insufficient data at this time to recommend administration of the probiotic for primary prevention of the Clostridium difficile outside the clinical trial. So the probiotics are also responsible for systemic bacterial and fungal infection. So there is no adequate recommendation that it will help in prevention of the Clostridium difficile infection. So this is the paper which is present in the NEGM that is that is based on the drug the basilotocumab, which help in the prevention of recurrent Clostridium difficile infection. So basically, this is the monoclonal antibiotic. Um, and according to this basilotocumab will help in recurrence of Clostridium difficile infection. And this another paper which was published in NEGM. And according to that, the use of oral microbiome therapy is effective in preventing recurrence of Clostridium difficile infection. Thank you, guys.